everyone. My name is Esther Kim, and I'm a cardiologist and vascular medicine specialist at Vanderbilt University Medical Center. And today we have with us Josh Beckman, who is an expert here in vascular diseases. And I thought I would pick his brain a little bit about pharmacotherapy in vascular disease. Hi, Josh.
Hi, Esther. Nice to see you.
Nice to see you, too.
Everyone needs to know that Esther's office is right next to mine at work, and we are close working colleagues. And I'm very happy to see my friend here interviewing me.
Well, thank you.
Now, make it very difficult.
So, Josh, we're at a conference called Vascular Interventional Advances. So, how important is pharmacotherapy in the management of patients with vascular disease?
So I think actually there's a couple of different answers to that question. First of all, I think it's incredibly important. Number one, there are medications that are used in vascular disease that save lives and save limbs. And we're seeing even more of those recently with the release of the COMPASS trial. Second, I think being a vascular expert, even if your primary expertise is in intervention, doesn't mean that the only thing you do is intervention. You have to remember that the people that are coming to you and the people that are referring to you both assume that you have expertise to manage all aspects of disease. And so when someone comes to you, you need to make sure that not only do they get the appropriate intervention or revascularization or exercise therapy, but they get the right pharmacotherapy, because I think that's part and parcel of all the outcomes. And intervention may be a small and narrow episode in the long arc of vascular disease of the patients. And so we have opportunities to make big changes in a short duration of time and big changes in a long duration of time by incorporating all the different aspects. The other thing I'll say is that the pharmacotherapy landscape now is really complicated. We have been very lucky that in the last several years, there's been a variety of medications, each of which can play an important role in the reduction of cardiovascular events, and some of them also in vascular events. And so I think that if you want to stay ahead of the curve and maintain your position of expertise, the pharmacotherapy is an incredibly important thing to understand, as well as the next balloon and stent.
I think jumping off of that thought, there are many different models for the care of the patient with vascular disease.
Yep.
And certainly mechanical intervention is just one part of that.
Yep.
So what do you think is the optimal sort of team management and care of the patient with vascular disease? Should the internist be involved? Should the cardiologist be involved? Should the vascular medicine person should be involved? How do you envision that providing the most optimal care for the patient?
So in a very interesting way, I think actually that we can control a lot of medical costs by bringing in more expertise in the management of the patient. And I like to think of the patient with vascular disease as following along a pathway. Everybody needs a medical home, because even if you have vascular disease, you have a variety of medical issues and screenings that need to occur. So if you don't have diabetes, that's with your primary care doctor. And if you do have diabetes, that tends to be with a diabetes expert. So one of those two folks. Then, in my opinion, certainly based on recent clinical trials data, you should be screened to see if you have peripheral artery disease. If you have peripheral artery disease, or you're screened and you're found to have an abdominal aortic aneurysm, you should probably get some advanced expertise. And whether that's a vascular medicine specialist or any of the other specialties that are well represented here, I think that's a reasonable thing to do, not just to make sure that that condition is okay, but that the medical therapy that's necessary to avoid other complications associated with it are applied. As patients begin to develop symptoms that are life-limiting, I think that they then need a higher level of therapy. And I don't think we know yet which is the better, exercise or intervention, but I do think that they're not the same, and we may end up needing both. So we figure out, based on what the patient is like, how can we make them feel better? And then if they have an ulcer, they've really just begun an odyssey that's going to take 6 to 12 months with multiple visits to the wound healing folks to try and accelerate the pace at which a now revascularized limb will heal the wound. But my job is not really just to see them in the beginning. My job is not just to reestablish blood flow. My job is not just to get the wound healed, What I want is someone who walked into my office to walk better after this whole process is done. And so we then need to begin to work, and now we have the opportunity to work with our rehab colleagues to get people to be able to walk further.
That's right.
And so I think it's an arc or a continuum of care. And by the time this whole process is over, they're back in their medical home, and they may be seeing the vascular specialist occasionally for sort of check-ins. But it's sort of a circle. It's a circle of life.
So with many things in medicine, it sounds like the team approach really is the right approach for the patient with vascular disease as well.
Yeah, I think everything that we can do to break down the silos is an important thing. And I'm going to go further than say the team approach. I think anytime you can apply complementary expertise to a problem, you're going to be better off. I'm not saying every patient needs to see every doctor every time, but once things begin to enter a realm of even a moderate level of complexity, at least conversations with other folks that you work with routinely, and then maybe even the occasional consultation is a good idea, because getting someone's expertise is not expensive.
Right.
What's expensive is waiting too long and having a procedure that's much more expensive that you may not have required.
All right, bringing it back to pharmacotherapy.
Yep.
So there's so much new going on in pharmacotherapy. It's a really exciting time for us medical people in the treatment of patients with vascular disease. So as someone who kind of has a pulse on the disease, not to be punny, what would you say are the top 3 medical advances in the past few years for the treatment of the patient with vascular disease?
Yeah, that's a really interesting question. Okay, so I think I'm going to give you 2 easy ones and one that I think may not be at the level of the radar yet. The top 2, I think, in terms of patients with vascular disease are, the first one was Vorapaxar and the second one was rivaroxaban. And I think the reason I picked those 2 is that in addition to whatever cardiovascular benefits they have, they're the first 2 drugs that have meaningful changes in your limb outcomes. And so as someone who cares about patients with vascular disease and peripheral vascular disease, I've never had a medical therapy that changed the direction of care over time. Now, there are drugs that we've used, like cilostazol, which may have made people walk a little bit better, but there's never been a drug before that reduced amputation, reduced major limb outcomes, reduced the rates of claudication. And so I think those 2 drugs are new and unique and maybe harbingers of things to come, where we are now beginning to understand that perhaps the thrombotic pathway at lower dose than, say, anticoagulation for a DVT has an incredible value. The third one that I'm going to pick is empagliflozin and the SGLT2s. And the reason I'm picking that one is that I think that is the first drug that I've seen that is a pill, because there's another drug from diabetes that reduces mortality, but it's the first pill that modifies cardiovascular outcomes really significantly. I don't know if empagliflozin, for example, has not been tested in the lower extremities. I don't know what it does there, but the reason I think it's not a hidden gem, but it hasn't really reached its potential yet, is that it's only now more recently becoming clear that it drops your renal threshold for glucose down to 40. So if you're a diabetic patient and your threshold is at 200 and you drop it down, you can see why just getting rid of extra glucose would be good. When it's given to healthy people, it also causes them to lose glucose in the urine. And what it causes the body to do is change the hormonal environment from one that makes you bring glucose into the blood system, because you're losing it, and you drop your insulin and you drop what makes you seem more like you have insulin resistance. So I think it's going to be the first metabolic therapy for patients with vascular disease and or heart failure. And so I think there's a lot more to come from that field.
I've heard you say that it may be the first anti-diabetic drug that is used not in diabetics.
Yeah, no, I think that's exactly right. So there are currently trials that are ongoing looking at it as a heart failure drug. If I had told you when they made these drugs that it was actually a high blood pressure drug, and you didn't care about the mechanism, except I told you that it was a sort of a diuretic and it made you lose a few pounds, and you had a drop in death. This would be the best blood pressure drug of all time.
That's right.
But instead it's a diabetes drug, and it does all the things I just said, and I don't see, what's always weird to me is that the diabetes community is not nearly as excited as I am about death reductions. They're still like, well, it's only a mediocre sugar drug. And I'm like, hello, you're missing the point.
Death is pretty important. So
that could be the summary for our whole talk. Death is important.
Death is important, so is life. So we've talked about these new, exciting new drugs that are approved or maybe in the pipeline. But there are still areas of vascular disease where we need some advances. So being someone who's sort of at the forefront and has a good overview of things, in what area do you think we are most desperately needing new drugs?
Yeah, so anytime we can develop new anticoagulants that have lower bleeding rates, that would be a good thing. Because there's just a huge number of people that should be on anticoagulants, and it's bleeding which really makes everybody afraid and limits their use. I think even though we've had dramatic improvements in public health measures like number of adults who smoke, we have no medical therapy at all for aneurysms. Anything there would be better than where we are now. I think fixing or improving our adjuncts for interventions would be really helpful. So, there's some ongoing trials now looking at some of the medications we talked about already to see if they make your interventions better. And so one of the things I would really like was that CMS would say, okay, a medicine that I'm giving you that makes your intervention better, that is an approvable indication for a medication. So far that doesn't exist. So I would say adjuncts to our current therapy. An example would be statins make carotid endarterectomy do better. Therapies for abdominal aortic aneurysm, because right now there's nothing. And then, continuing the new discovery in anticoagulants so that maybe we can even lower the bleeding rate even further.
Perfect. Finally, we've shown in multiple studies that despite having pharmacotherapies that save lives, prevent cardiovascular effects, and help people feel better, that these things are way underutilized. So do you have any advice or strategies you can give the vascular practitioner on increasing utilization of the drugs we already have?
Yeah, so in a way that I really don't want to lay the blame at anyone's feet, because I suffer from the same problem. It is impossible to manage all of these risk factors with 2 15-minute visits a year. There's just no way that when you have 15 minutes, particularly if you're a primary care doctor and you may have 1 visit a year, that you're gonna be able to have all the conversations that are necessary to get this done. And I think that there's a financial cost which is not measured well on a utilization basis, because if you do everything right, people don't go to the hospital. But I think as we begin to move towards more capitated care and bundled care, we need to spread out episodes so that they encompass a longer period of time, and we need to begin to involve people who can, the word is not assist, but I would say extend the physician's capabilities. And I'll give you an example. I think, and it's perfectly reasonably possible to have a nurse or a pharmacist follow specific management strategy and an algorithm for the management of high blood pressure and lipid management. So when you have a patient who meets the criteria for those things, a collaborative partner should be able to call your patient and talk to them on a monthly basis to get this person to control. And I think that does 2 things. One, if you have someone who's talking to the patient on a monthly basis, you don't need to see them in 6 months. You need to see them in a year or 18 months, because you have an early warning system for problems. And then you also know that the patient actually feels like they're getting more care because they have more touches with the medical system, and using sort of the responsibility of multiple conversations kind of model, they are more likely to take their medicines and keep in control. So I think the answer is, fill-ins for people who can bring more care to the patient but use fewer physician resources.
Well, thank you, Josh, for your insight. This is all the time that we have. Just want to thank you for all the work that you do for vascular practitioners and patients on a nationwide basis. It's been great talking to you.
You're very kind, and thanks for having me on VIVA Unscripted.
All right.